Good morning, my lovely nurses. I hope you are fine and your family is good. So, previously, you see my lectures. The previously we are discussing. We discussed hyperkalemia and hypokalemia. Our coming lectures are also related to electrolytes. So today our electrolyte lecture is hyponatremia. Hyponatremia. What is hyponatremia? Decrease sodium. So first we have to know what's the normal value of sodium. Normal value is 135 to 145 MEq per liter or 135 to 145 millimole per liter. This is the normal value of sodium. If the sodium is less than 135, it means patient have hyponatremia. And one more thing, always keep the sodium imbalance usually are associated with fluid volume imbalance. What's the mean of this one? If we have fluid volume imbalance, it's mean we also have sodium imbalance. So this is hyponatremia definition. Now we will discuss the causes. So causes of hyponatremia, the first is increased sodium excretion. The first one is increased sodium excretion, mean the sodium is coming out. So how the sodium is coming out from the body? Number one, excessive diaphoresis. Number A, excessive diaphoresis, mean patient have too much sweating. Number two, diuretics. Patient is receiving diuretics. Due to this reason, patient have excessive urine output. So patient have the problem of hyponatremia. Number C, vomiting. Number D, diarrhea. Number E, wound drainage. Wound drainage, especially GI, the gastrointestinal. Number F, kidney disease. Number G, decreased secretion of aldosterone. Decreased secretion of aldosterone. Because due to decreased secretion of aldosterone, we have serum electrolyte imbalance. Then number two, we will discuss, before we discuss number one, increased sodium excretion, how sodium is coming out from the body. This is the reasons of the increased sodium excretion. Now the second is inadequate sodium intake. Inadequate sodium intake. So which points will come in the inadequate sodium intake? Number one, the A, fasting, nothing by mouth status, NPO, nothing by mouth status. The patient have inadequate sodium intake. Number two, low salt diet. If patient is taking the diet that have less sodium, less salt, the patient also have the cause of hyponatremia. Then this is the number two. Now number three. Number three, what's the point? Dilution of serum sodium. Dilution of serum sodium. So which points will come in the dilution of serum sodium? Number one, excessive ingestion of hypotonic fluids or irrigation with hypotonic fluids. So It's mean if patient is taking too much hypotonic fluids, what will happen? Our sodium that is available in our body, the normal sodium 135 to 145, what will happen? That will dilute, because too much hypotonic fluids patient is taking, and the inside sodium that we have in our body, it will dilute with each other, and then what will happen? The hyponatremia will happen. The less sodium, hyponatremia, because it's dilute. And if the patient, the irrigation of the hypotonic fluids, if we are using too much irrigation with hypotonic fluids, it will also cause the hyponatremia. In the dilution of serum sodium, the point B is kidney disease. Point C is fresh water drowning. If patient drown in the fresh water, it can also cause the hyponatremia, because the more water he will ingest, and what will happen? This is hypotonic, the fresh water, more water he ingest, and our inside body, the normal sodium, it will dilute with the water, and patient will cause the hyponatremia. Then hyperglycemia. The patient with hyperglycemia also have the hyponatremia. Then F, heart failure. Heart failure patient also have the hyponatremia. The excessive fluid cause the excessive fluid, hypervolemic, also cause the hyponatremia. Now the assessment. How we will assess the patient of hyponatremia? It's depend also according to the systems. So first we will talk cardiovascular. If we will talk cardiovasculars, that is symptoms vary with changes in vascular volume. It's depend on the vascular volume of the heart. It's depend on the vascular volume of the heart. For example, if patient is hypovolemic, what will happen? If patient is hypovolemic and he has hyponatremia, what will happen? The thready, weak pulse, and rapid pulse. Patient have thready, weak, rapid pulse if patient has hypovolemia. Flat neck veins, normal or low CVP, normal or low CVP, central venous pressure. If patient has hypovolemia, if the hyponatremia, the cause of hyponatremia is hypovolemia, then patient have thready, weak, rapid pulse, and number 2, flat neck veins, and maybe the CVP, central venous pressure, may be normal or low. But if patient has the hyponatremia is the cause of hypervolemia, due to hypervolemia, if patient is hypervolemia, then what's the sign and symptoms will be? In case of hypervolemic, rapid bounding pulse. In hypovolemia, thready, weak, rapid pulse, but in hypervolemia, rapid bounding pulse. Blood pressure may be normal, BP may be normal or elevated. The CVP may be normal or elevated. The central venous pressure may be normal or elevated if hypervolemic is the cause of hyponatremia. If we will talk about the respiratory system, how respiratory system will affect due to the hyponatremia. So it's depend on the weakness of the respiratory skeletal muscles. For example, the respiratory rate may be shallow, ineffective respiratory movements, ineffective respiratory movements and is a late manifestation. This is the late manifestation. If we will see the patient of the hyponatremia, these all manifestations are late. Shallow, ineffective respiratory movements. Why? Because this is related to skeletal muscles weakness. Skeletal muscles weakness. Due to this reason, patient have shallow, ineffective respiratory movements, and that is late manifestations. Now, the next system is neuromuscular. Neuromuscular is generalized skeletal muscles weakness. Generalized skeletal muscles weakness that is worse in the extremities. That is worse in the extremities. Extremities mean on the legs and the arms. Diminished deep tendon reflex. Deep tendon reflex. When doctor will check the deep tendon reflex, it will be diminished. He cannot properly observe the deep tendon reflex. Now the GI, gastrointestinal. Patient may have nausea, increased motility, and hyperactive bowel sounds. Hyperactive bowel sounds and abdominal cramping and diarrhea. Abdominal cramping plus diarrhea due to hyponatremia. Then the renal. In the renal, increased urine output. Increased urine output due to hyponatremia. If we will talk about integumentary, mean our skin, the skin will be dry mucous membrane. Dry mucous membrane. What lab test we will do? The lab, of course, we will check the sodium level. It should be 135 to 145 millimole. If it is less than 135, it means patient have hyponatremia. And we will check the urine. In the urine, what will happen? Decreased urine specific gravity. Decreased urine specific gravity. Why urine specific gravity will be decreased? Patient have increased urine output, and due to diuretics, the sodium less in the body, and what will happen, our sodium is diluted with the fluid, and due to dilution patient have decreased urine specific gravity, and this when we can see in the hyponatremia patients. Now what intervention we will do? Intervention of hyponatremia patient, it's depend. For example, if hyponatremia is accompanied by fluid volume deficit, fluid volume deficit mean hypovolemia. If the reason is hypovolemia of hyponatremia, then IV sodium chloride infusion are administered to restore sodium contents and fluid volume. So we will give IV sodium chloride infusion to increase the sodium level in the body in case of hypovolemia. Now if the patient is, the cause is hypervolemia. If the cause is hypervolemia, then in this case osmotic diuretics, not the other diuretics. We will give only osmotic diuretics. Why we will give osmotic diuretics? To promote the excretion of water. To promote the excretion of water rather than sodium. So this osmotic diuretics, what they will do, they will excrete only the water, they will not excrete the sodium. So it will help in the hyponatremia patients. Sodium will stay but the water will excrete. Then we will instruct the patient to take sodium diet to increase the oral sodium intake. Increase sodium intake, and he will choose foods that have more sodium. Very important point, if the client is taking lithium, some patients are taking lithium, so always monitor the lithium level. Why we will monitor the lithium level? Because hyponatremia can cause diminished lithium excretion. If patient has hyponatremia and patient is taking lithium, so we will check always the lithium level, because what can happen, the hyponatremia can cause diminished lithium excretion. So lithium will not excrete from the body, then what will happen, toxicity will happen. So hyponatremia precipitate lithium toxicity in a client who is taking this medication. If patient is hyponatremia and he is taking lithium medication, we always check lithium level, because in case of hyponatremia, the lithium will not go from the body, it will stay in the body and it can happen the toxicity. So lithium level we should have to check and monitor properly. I hope you like the lecture. If you like, please share and subscribe my channel, and don't forget to push the icon bell button so you can receive my coming notification. Thank you very much. Take care of yourself and your family. Allah Hafiz.